the major reasons why they land up in problems is failure of venous access or thrombosis, stenosis, and these are the key problems which many of these patients face. And endovascular means is very important and crucial in maintaining patency of these vascular accesses. There is a lot of evidence which has been there for the past decade or two, wherein endovascular salvage of failing fistulas, grafts, and basilic vein transposition is proven. And there have been comparisons between surgical revision or endovascular salvage of even thrombosed dialysis access. And it was noted that as compared to surgery, endovascular salvage actually fared better, because with surgery, all we do is just remove the thrombus. But we all know that after thrombectomy or thrombolysis, there is usually an underlying lesion for which angioplasty is often required. So, as compared to surgery, endovascular repair of thrombosed access has been proven to be better. However, there are a number of challenges that all of us face. One of the most important ones is a timely referral of a patient. We would have seen that patients end up being referred late. The second important part is the nephrologist's belief in dialysis access angioplasty. Once we have done a dialysis access, the patients usually will follow up with their nephrologist. So having them to share a similar view is very important. Otherwise, they themselves will counsel that it's of no use going for an angioplasty. Let's do a permacath. That's another challenge that many of us face. Third is the patient's willingness for an angioplasty. Fourth important challenge is our vascular surgeons' resistance or acceptance for dialysis access angioplasty. And lastly would be availability of the expertise and the facility. There are a number of logistic challenges that are also present, but this is otherwise not a very difficult angioplasty. And for people who work in private sector in smaller hospitals like we do, even a small cath lab or CM based cath lab with Doppler can be sufficient to perform these procedures. Whereas in corporate hospitals, we've often seen that because there's a fixed cath lab, many of us are at the mercy of cardiologists, and vascular surgeons get a less priority. You'll have a cardiologist saying that we have a PAMI patient which needs to be taken urgently, but would they or the management let us take a dialysis access patient which with that efficiency or speed? I doubt so. And from our perspective, the time and effort which we spend behind it compared to the remuneration, the availability of hardware, and affordability of patients. So these are challenges that many of us face, irrespective of the kind of setup where we practice. Coming to the indications for dialysis access angioplasty, this is a list of the indications, but the most common one is venous access dysfunction leading to high venous pressures. This is a Doppler diagram which shows that this is the size of the vein. This is the stenosed vein beyond which the vein is good. So because of this venous stenosis, they often end up with low flow rates, high venous pressures, leading to bleeding, and occasionally when they're not recognized in time, they end up with thrombosed dialysis access. Apart from this, pain during dialysis and venous hypertension, patients who have a central venous obstruction or stenosis would present with massive limb edema. So just a few photographic examples of what and when dialysis access angioplasty is required. That's a patient with a basilic vein transposition. We can see that the vein here has developed fairly well. This was done 2.5 years ago, but the vein beyond this has been stenosed and is unable to allow proper flow. So because of venous hypertension, she kept on developing repeat bleeding episodes, or it can end up with such kind of aneurysmal dilatation, and patients with central venous occlusion that we all know would end up with massively swollen limbs. The classic protocol for treating dialysis excess thrombosis is, as surgeons, we must always see if a simple new fistula is possible. Yes, that can be the first line of treatment. But if a new fistula is not possible, then we have options. Some of us may opt for going for a basilic vein transposition or a graft. Some of us may do just a surgical thrombectomy. Some of us may prefer to do an endovascular, either thrombolysis or thrombectomy, and follow that up with an angioplasty. Our preference is an endovascular first for very precious fistula, and this is the practice that currently we follow. If it is a thrombosed fistula at the wrist or forearm, we prefer a fistula at a higher level. If it's thrombosed at the elbow, the first option is doing a basilic vein transposition or a contralateral AV fistula. But we have done a lot of these patients where it's a precious fistula. They do not want a new DLC or a permacath insertion, and we want to get the access working faster. We have done dialysis access angioplasty for many thrombosed fistulae. Before surgical revision, we must make sure that the central veins are patent. For thrombosed basilic vein transpositions and grafts, our preference is to do thrombolysis and angioplasty. And for central vein occlusion, again, an angioplasty is our preferred choice. The basic procedural steps, it's a puncture which is done under ultrasound guidance. Our choice of access for most of these patients is the brachial artery, but we must remember that in that we only go till 6 French. However, fistula vein, occasionally the axillary vein, or sometimes the femoral vein access may be opted for. We have to do a complete DSA from the anastomosis till the SVC to evaluate for any thrombus or stenosis. The preferred guide wire is a Terumo glide wire with a catheter support, and the balloons that we prefer are high pressure balloons. We use a stent only if there is a recoil and there is a residual stenosis of more than 30 to 40%. The closure of excess site, if it's an artery, it's just manual compression. But with a vein access, we often do, and I'll show it later also, how we do a purse string suture for closing the puncture sites. As I said, we select the access depending also on the lesion. So we do an ultrasound to find out where the exact lesion is. So that's a patient with an elbow fistula, a failing fistula, and we can see that there is a stenosis which is juxta-anastomotic. There are two ways to approach this. One is to come from above through the vein. We prefer going from the brachial artery and into the vein and doing an angioplasty from this route. Whereas some operators do prefer coming in from the vein and going down. However, we must ensure that whichever access we choose, there must be a reasonable working distance for us to manipulate the guide wires. If there is a higher lesion, wherein it's either at the axillary level or the central vein, then a venous access can be chosen. And occasionally, like in this patient, we may need a femoral access with an axillary or a basilic access. So two accesses may be required in some patients. For crossing the lesion, it is important that we find the correct angulation of the anastomosis, and many a times we need to see the angio in 2 or 3 views to give us the correct approach. So for example, this is a patient with an elbow fistula. That's the brachial artery which is opacified. We can just see a small nub of the anastomosis, and we have to poke in with a guide wire and a catheter, and then we go into the access. We use an angled catheter because usually anastomosis will be at an angle. and Terumo wire is our preferred choice. Many of these patients we have to use short sheaths, but occasionally when we are working for the central vein, a long sheath may be used. And as I said earlier, rarely multiple access may be required. In case these wires don't pass and there's a very thin channel, we sometimes may need a micro wire to pass through it. And for central vein occlusions, where the occlusions are non-passable by the regular end of the guide wires, we have used the stiff end of Terumo, but that's where the chances of perforation are there. So you must always ensure that we don't go too deep with a stiff end of the Terumo. The challenges that we often face when we have to enter into the vein, as I said earlier, that this is an angle of the anastomosis. So if we put in a catheter in the brachial artery and orient it towards the vein with an angled catheter and a wire, we are usually able to pass across into the vein. And we may have to see a right and left oblique to identify the anastomosis, and we have to see just such small projections of the anastomosis so we know where to poke. Whenever we do a puncture in the artery, we make sure that the contrast pushed is not very forcefully done. Otherwise, it can cause reflux back into the artery. And we don't do too many angiographies before we pass in a catheter up. And once we are beyond a certain limit, then we assess still the central veins. For thrombosed fistulae or transpositions or graft, we usually prefer to use urokinase, and we use the pulse spray technique. We dissolve 5 lakh units into 25 ml of distilled water, and every 30 seconds we forcefully push it by a 5 ml syringe through the sheath or the catheter which lies in the thrombosed vein. We make sure that we don't just push the thrombolytic into the artery because we want it to reach at the site of thrombus. Along with a thrombolytic, what is more important is doing ballooning as well as external massage to cause what is called as clot maceration. And it is a combination of all three which helps to remove the thrombus. After balloon angioplasty, we again check by an angiography. If an underlying stenosis is found at different sites, we do a balloon angioplasty again, and we stent if the residual stenosis is more than 30%. There have been different techniques for using thrombolytics. So the one that I mentioned and which we use is a combination of wire lacing maceration and a pulse spray, whereas some people also use a lytic, which they give 2 hours prior to the procedure and then take in the cath lab. And we have used mechanical and pharmacomechanical thrombectomy devices of late, and we have found them to be fairly useful. The hardware that we have to use once we have crossed the occlusions is a plain old balloon, but what is more important is having high pressure balloons, because many of these stenoses are fairly resistant to regular balloons, and I'll show photographs of some of these lesions. We may have to use the special non-compliant balloons like Conquest and Atlas for the larger diameters. Occasionally, there is requirement of a cutting balloon. There have been studies where drug-coated balloons have found to be superior, especially in the durability of the procedure. And occasionally that we have to use a self-expanding stent, and rarely a covered stent. So as I said earlier, that when do we accept the balloon angioplasty? That is a normal balloon which we used at 14 atmosphere RBP. We still see a waist here. So we went ahead with a high pressure balloon, and we had to go as high as almost 22 to 24 atmospheres to get rid of that waste. So this, unless we see this picture, we know that the angioplasty has not worked well. We cannot accept this stenosis or waste on a balloon and think that this angioplasty is going to last longer. So that's another patient where we did use a normal balloon, but we see a waste with this balloon. We used another balloon, following which we see that the waste has cleared, and after the high pressure balloon, the vein is now fairly well seen. There will be times when there may be a borderline, what we call as a acceptable or a mild residual stenosis. That's a patient with basilic vein transposition. This is the classic area where we see a swing stenosis and we see a very thin line of the stenotic basilic axillary vein, which after balloon we can see even there is some amount of mild waste at even 22 atmospheres, and the end result is not very good, but it was deemed to be acceptable. And even at high pressure balloons, if we see such a waste, then this is an indication for using a cutting balloon. So that's a patient with a basilic vein transposition where uh, it was a very narrow waist which was noted after balloon angioplasty. So we used a cutting balloon, and following which we see that the final result was fairly acceptable. There may be time when after a balloon angioplasty, there is severe recoil, or some people call it as an early restenosis, but ideally it is a recoil because it occurs immediately. This cannot be left like this, or the access will close off again within a couple of days. So here we put in a stent, and we often stent these lesions even when they are, even when they come with a thrombotic occlusion. But once the thrombus is clear and we achieve such a result, we cannot leave it like that. We do a stenting in the same session. These are the few steps of how we treat. This is a basilic vein transposition. It was a thrombosed one. That's the wire which has entered into the vein. And after a thrombolytic, we see that some amount of flow has come. We again did a balloon, and then again thrombolytic was given, and the end result looks fairly good. Uh, a couple of examples for this is a failing fistula. We see multi-level stenosis in the whole elbow AV fistula, right from the juxtaanastomosis to the midarm. And because of these stenosis, sometimes these veins are uh, very small in caliber, but a long-standing fistula, we must assess the diameter of these veins on an ultrasound, because even a fistulogram may show a small vessel, but to decide the size of balloon, we have to take help of the ultrasound or Doppler too. And that's the patient's result after the angioplasty. The fistula has worked fairly well. That's again a basilic vein thrombolysis with an angioplasty and a fairly good result. Sometimes we may see such residual thrombus which are more of organized thrombus, and on ultrasound we confirm that if it is only at the edges of the vein, then we do not do much for that. EV graft also very well treatable with thrombolysis and angioplasty. Moving on to central vein stenosis, that's a patient who developed lymphedema after a basilic vein transposition, and we see there's a innominate vein stenosis which didn't respond to just balloons, so we ended up putting in a stent into that. Another patient who developed lymphedema after basilic vein transposition because of a occlusion of the innominate vein, but here this patient responded fairly well to balloon angioplasty, and she had rapid reduction in the edema, and the vein could be used for cannulations. Sometimes we do see suboptimal results of central vein angioplasty. That's a patient who had multiple collaterals and limb edema. We've done a balloon angioplasty, but however, the result, as we see, was suboptimal, and the result is much better after we have put a self-expanding stent. That's another patient with massive limb edema, and after a stent, a few weeks later, we see that the limb has come to a normal size. Cephalic arch is again something which we'll encounter for elbow AV fistula failures. And if it is a stenosis which is like this, right at the cephalic arch, then they do fairly well with angioplasty. But over time, these lesions do keep coming back, and there are many evidences that the placement of covered stents in this location is superior to balloon angioplasty or even angioplasty using drug-coated balloons. But even at the cephalic arch, there are two things which we must remember. One is that if the stent gets occluded, it can hamper or cause stenosis of the subclavian vein and lead to problems in another axis. So we must ensure that the stent does not protrude too much into the subclavian vein. And the second possibility of rupture, which is reasonably common at this segment, especially where the diameter of vein is so much different. Here we see there's a free rupture of the cephalic arch, for which we had to put in a covered stent and salvage it, and then the fistula worked fairly well. We do see rupture at occasionally different sites, and that's a patient who had a perianastomotic uh, stenosis, and after a balloon angioplasty there was a free rupture here. So we did try with balloon angioplasty, but the rupture we see is a fairly large one, so we had to put in a covered stent at this location. Again, as I told earlier, if there is residual thrombus, we must evaluate on an ultrasound. And we have seen that even thrombus like this, they can go away with thrombolysis, clot maceration, and ANGIOJET has helped us very well, where there are a lot of organized thrombus in there. And sometimes patients like this, wherein there have been organized thrombus which has not responded even to angiojet, there putting it localized stents can help in achieving patency for a better duration. Angiojet, as we all know, is useful for all thrombosis patients, and we have used this in many patients with dialysis access thrombosis. And our protocol is that we do thrombectomy for 60 to 150 seconds, repeat the fistulography, and we see that some of these patients do not need any thrombolytic. But if they do, here we use TPA in these patients with a dwell time of 30 minutes. Then we again repeat the thrombectomy, again do the fistulography, and then proceed and do an angioplasty if required. And with an angiojet thrombectomy, we have seen really good results. That's a patient with a thrombosed basilic vein. We can look at the diameter of this vein after a simple balloon was not even adequate, because the patient had come with a 1-week-old thrombosis. So after an angiojet thrombectomy, and a stent in the axillary vein, we see that the diameter of the vein has become fairly good. This was a 2-year-old working basilic vein transposition, and again it has been used for more than a year now. Patients with thrombosed AV graft, that is again where angioplasty can be useful. So here we use 2-access methods to go crisscross into the arterial side as well as the venous side. And we can use angiojet if possible, or thrombolysis and angioplasty, and grafts do work fairly well. What we have to take care is usually there is a stenosis at the distal end or the venous end, which may need treatment. That's a video of how we have done or how we do angioplasty. We can see that the guide wire is going through the axis, and here we see thrombus almost till the cephalic arch, whereas the subclavian is fine. We see some stenosis at the cephalic arch here. So we did a balloon angioplasty for the whole segment. We use different sized balloons, as we see that we use different sized balloons for the cephalic arch and this proximal cephalic vein. And after that, we see that the vein has opened up fairly well and the flow throughout the vein is fairly good. And good clearance of the thrombus was achieved. And this patient's fistula worked for 6 more months before we had to do a re-intervention. So a few words about the closure of venous access sites. We do take a venous puncture, and this video shows how we take a purse string suture around it. If we see that between a vein and the skin, there is usually not much distance. With such good caliber veins and which are superficialized, there is not much distance between the skin and the vein. So even if we are able to close the skin fairly well, we do achieve good hemostasis. So this picture on the right shows this is the sheath in place, and after we have put in a purse string suture, we see that this patient didn't even require any further compression. This is important when we use larger diameter sheets, especially 7 or 8 French sheet, that these punctures will tend to bleed. So just manual compression may not be good, and using these purse string sutures is a really useful technique. In the video, we see that's a 8 French sheath, and I'm closing it with the puncture site with a purse string. So usually, even after a purse string, if there is some leakage of blood like we see in this, it does stop with just 10 minutes of manual light compression, and we don't need to really push hard on the compression there. That's another patient with a dialysis access, wherein it was a fistula which had been working for more than 3 years, a large diameter vein that we see here, but there is thrombosis beyond the mid-arm. While passing wires, it is important if we have some base mark or some road mapping. Here the dye is as such visible in the vein, so we should know where our wire is going. Otherwise, sometimes we end up perforating these veins. Here we see there is thrombosis in the entire cephalic vein, whereas the central veins are fine. So we did a thrombolysis, and then we did a balloon angioplasty of the whole vein. So we keep doing the balloon angioplasty in steps. And even after that, we see that some amount of thrombus is there, but the flow was still sluggish. So there was one area of resistant stenosis right here at the deltopectoral groove, and we can actually see the cephalic vein right till here, and then the arch fills up fairly well. So we had to do we used a high pressure balloon at this location, and after we used a high pressure balloon here at the deltopectoral groove, the flow was fairly rapid and the fistula is working fine now. So to summarize, the learning points for all of us is that endovascular means form an important part when we want to achieve a salvage of our dialysis access. It is important that we educate not just the nephrologists, but the technicians and the patients, because the way that we work is we educate all our patients that even if your technician or nephrologist says that this fistula is thrombosed, at least if possible, come to us. We should do an angioplasty and get it flowing back again. We have to have an established referral system for dialysis access patients, wherein it's easier for them to come in time, because patients who develop a thrombosis should be treated as early as possible. There is a certain learning curve to this procedure, and it can be crossed The more we do, the better we get at it. And everyone, including us, the patient and the nephrologist, we all have to be prepared to do it again and again. And that's a patient of ours who has been coming for re-interventions, and they are happy with the result, and that's why they keep coming back. So that's a patient who over 1.5 or 2 years has come for 3 interventions to us. And at the end, we must not forget that if endovascular means fail, we know that as surgeons, we do have surgical alternatives. This is a patient with a fistula who had massively swollen right limb with so many collaterals. Angioplasty was attempted twice, once by us and once elsewhere, but was unsuccessful. So we did a venography and checked the opposite side was fine. So we made a fistula on the opposite limb, and after it was functional, we ligated this right-sided fistula, and this is the patient 3 years later. Both hands are fine. This left fistula is working, so he is happy. So we should never forget surgical alternatives do exist, and not everything can be treated by endovascular means. Thank you so much.